Thank you very much for inviting me to this, I think, very important seminar. There are many things we can learn from the pandemic, but how to deal with ethics is definitely one of them. And unfortunately, last week we had a meeting of many of the public health agencies all over the world here in Stockholm. And we discussed, of course, the pandemic among many other things. And we all agreed that we tend to be in two phases when it comes to pandemic. Either we are in the forgetting phase, or we are in the reaction phase. Like you already said, we have a very close tendency to, once the pandemic is over, to try to forget all of it and go on. And therefore, I think it's so important that we now, this time, come back and try to really remember and try to learn this time. And how to involve ethics in this is one of many learning things we need to do. First of all, I think that, and we discussed this many times, context is so incredibly important. I think previous speaker also talked about that. How we react to pandemics, how we involve ethics, so much depends on the ethics we're living in. And I mean, most of you already know this, but I usually show this because I think it's very important to understand where you are when you talk about how we manage pandemics in different parts of the world, because we have so different possibilities to do different things. One thing which is not said here, which is very important, that in Sweden we cannot declare a state of emergency. There is no special powers that come into being just because we are in a pandemic. So we need to go back and use the legal and other structures we have in place also during a pandemic. We'll see if the present review will change that, but this is very much the sort of basis of Swedish preparedness. Whoever is responsible for some kind of activity in the society during peacetime is also responsible when we have a crisis. The only thing that changed that is actually a war. The other thing is how extremely decentralized the Swedish healthcare and public health system is in Sweden, which really gives extra challenges and makes, especially this with trust, so incredibly important, because there is really nobody in Sweden that can tell the regions or communities in Sweden exactly what to do, except in very specific circumstances. So we need to have this as a background when we deal with pandemics. And the other context is, of course, what do we know from previous pandemics? The Spanish flu, which we know reasonably. I mean, there's been pandemics going back to thousands of years. Probably started when we started moving into cities instead of living, just gathering our food out in the countryside. Spanish flu is probably the first one we know a little bit more about. And there, the consequences were extreme. Probably at least partly due to that this was the end of the First World War. There were many people who were very vulnerable, and we also had a big movement of soldiers over the world that really caused. The Asian and Hong Kong flu, not incredibly quickly forgotten. I mean, if you go back and try to sort of understand what happened after this, not much happened at all. The swine flu, which is not only a little bit more than 10 years ago, also quickly forgotten, even if the impact wasn't that bad. And now we are in the middle of probably the worst pandemic we had since the Spanish flu. Many of the consequences we don't know completely yet on the health system, long-term COVID, many chronic diseases, many screening programs and so on that didn't work as they should. And the effects of the measures, we don't even know really what they're going to end up being. And another context that's often discussed is what you call a precautionary principle. That was often quoted, and that's why I sort of had to look it up in several places to try to understand what does it actually say. And the precautionary principle does not say what many people said during the pandemic, that you should do as much as possible. It rather says you should do as little as possible, not to damage too much. And so it's often misused as a principle that we should have followed. And I think actually Sweden in many ways followed the precautionary principle much more than many other countries, which I think is an interesting aspect and really a need to have these kind of discussions before we end up in a crisis, because then they are very difficult to have. And the precautionary principle very much goes back to the environment and the need not to start doing things that can damage the environment more than necessary. But I think it's interesting that the the principle is really about not doing too much, instead of not always do everything. The other important term that we often come back to, and it's very clear in the Swedish legal text many times, is the context of proportionality, that we are not really allowed to do more than we necessarily need to do to handle a crisis. So that once again is something that we very much thought back on when we discussed what to do during the Swedish pandemic response. And especially measures directed to the individual is something you have to think very carefully about before you start doing them. So, I mean, all of you have probably seen this slide so many times that you're pretty sick of it, just as I am. But I think it's also important to come back and understand what was the sort of main principle of pandemic management in the plans we all had discussed after the previous pandemics, and also in the pandemic plans that were discussed in many places all over the world. And that is really you need to get the number of people that are sick at one single time down to a reasonable level. And I think that's very much what it's all about. I think history has taught us that we can never stop a pandemic. I mean, we have tried all over the world, and now we heard just the other day that even China has given up the concept of actually stopping a pandemic, unless you do it at a very, very early stage. Once it's a pandemic, it's basically unstoppable. And then you need to instead work with trying to get the consequences down as much as possible. And those are very much based on how many cases you get at one time. And that's the way we have to minimize mortality and morbidity as much as possible. And in that, of course, comes that we need to think about risk groups, we need to have tailored measures and intervention, and we need to do things that are sustainable over time. We also know that pandemics will last for a long time usually. And one group this is a slide from Norway, but we could have shown exactly the same slide from Sweden. And this shows how many years you have left to live, depending on what level of education you have. And I think that in most countries you can show similar slides, how big differences there are between different parts of our population. And these come back to probably the groups that I think were worst hit in many countries. And that's what you call the hard-to-reach groups, and you can name them in many different ways. And also, and this is a bit busy slide, but it shows another connection to the differences we have in public health in our society, and that's, of course, very much related to education level, but that's the country of origin. And this shows very clearly how much the risk, both of ending up in intensive care, but also actually dying from COVID-19, is related to your country of birth. And I think this is one of the lessons we really need to take with us, and it's very much also an ethical question. How could we sort of have missed to get these people involved in our societies to help alleviate also the risk in these groups? Because as you can see, being born in Africa increases your risk of ending up in ICU or ending up dying from COVID-19 is 5-6 times higher than the population in general, which is a level of risk that we only find in the very, very old otherwise. So if we should learn something from the pandemic, I think this is the one ethical issue, which I think is one of the most important ones. How do we actually find ways of reaching and protecting the risk groups better? Public health, I think the ethics is a little bit different from the ethics in healthcare many times, because ethics in healthcare, as I understand it, not being really involved in the science of it, is very much about the individuals. Here we talk about how do we relate risk for the individual compared to the risk for the population. Many of the decisions that we took were, of course, very much related to the individuals. It was who do we test, how do we contact trace, treatment, who should be taken into intensive care to get the treatment there, how do we quarantine people and how do we isolate people and so on. So many of them were connected to the individual. But in many ways, at least from my point of view, these were a little bit easier from an ethical perspective because healthcare in Sweden has an ethical platform, as we already heard about, and there were at least sort of a continued discussion on how you should prioritize in that. It becomes much more difficult when we talk about the non-pharmaceutical measures, like lockdown, all of these apps, travel restrictions, school closings, and all the other things, because there we don't normally have these kind of discussions. And I really believe, like you said, that we need to have this discussion before the next pandemic so we can actually sit down and think through how do we take these kind of decisions in a way that takes in all different aspects into play, not least the ethical ones of them. Because there is always this scale that you have to think about, and I think this scale that we often came back to in the public health agency. How do we sort of weigh the possible positive things we get from a measure towards the negative things of the measures? And I think in the general discussions, especially during the early pandemic, there was very little discussion about the risks we do in different things. And I think schools is a very, very good example of that. We know from a lot of research that the loss of education really has an increased risk for many, many things, not least in public health, mental health, and many other risks. If we close the schools, we might lower the risk for the individuals. We didn't really know that very well, and we could maybe have less transmission in the society. And we need to sort of think about how do we actually land a decision having these two parts of the scales, and how can we involve the ethical dimension in taking those decisions. Restaurants is another such area. If you don't regulate them, the negative things is a lot of people are going to have loss of work, which we know is very important for public health to be able to keep on working. The economy will get worse, which is also bad for public health. We might, if we close them, lower risk for individuals. We didn't know that very well. Later on, we could actually follow up on how high was the risk if you worked in the restaurants. And it was slightly higher than the people in the community at large, but not that much higher. Was there a high risk of transmission in society because we have restaurants open? We don't know for sure, but what we could look at so far, and when we look at contact tracing, is that no, restaurants is not a place where there's a high risk of transmission. And if you regulate them, you will have a lot of consequences for the economy, but of course, you might lower the risk for the individuals. A third area is the big events that we dealt with in different countries. You can have more or less the same arguments around those if you don't regulate them and if you regulate them. And once again, you have many individuals that will suffer because they will lose work. The economy will suffer because this is a big income for many individuals. You might have some kind of effect on the transmission in society, but we didn't know very well in the beginning, and we still don't know how important it was. So I think there is a number of challenges that we need to think about when we start discussing about how should we get ethics better integrated. One of them is, of course, that we need to integrate them already in the planning. We have done that to a certain extent in the Swedish pandemic plans. There is actually a section on the ethics, even if it's not very well developed. We need to be better about weighing the risk for individuals versus the risk for the population. I think that's a very difficult area that we don't often discuss. We have that discussion in public health sometimes in the area of vaccines, in the area of screening, but these are kind of silos, and we need to widen them more into the general area of public health and look at that. We need also to discuss, I think, more about the integrity of the individual. How far are we prepared to go during a pandemic to actually not keep the integrity at the level we are used to. And then, of course, as was mentioned before, a number of decisions needs to be taken on very loose knowledge, and the knowledge that probably develops very quickly, which also means that we need to change decisions during a pandemic. The fourth, I think, is maybe the most tricky area, is that we need to take decisions quickly. There was quite a lot of complaints about our decisions were too quick because many of the regions and communities didn't really have time to act on them. But on the other hand, when the knowledge changes, as it does during a pandemic, we need to take these decisions quickly. And then how many actors can you involve? And is it possible to have some kind of ethical grouping that you can get sort of their opinion basically from 1 hour to the next? And how do we arrange that in a reasonable way? And last but not least, how do we handle equity? Like I showed in the beginning, the equity when it comes to health in the Swedish society, and probably most societies in the world, is not optimal, and it's actually getting worse. I think we are getting into a world where the difference in health between different parts of the population is becoming more important than the difference in health between populations. And we need to handle that so we don't also in the next crisis see parts of our population that are damaged much more than the population at large. And we need to prepare for the unknown. I got this from one of my UK colleagues during the bird flu sort of pandemic many years ago. We thought it was a very nice illustration of that we don't know what's going to happen next. Interestingly enough, this picture stops at monkeypox, which nobody 10, 15 years ago ever believed was going to happen, be a public health threat. So that's only to show you that whatever we guess that's going to be the next problem, we're probably going to guess wrong, unfortunately. And we need to prepare for the unknown and be very flexible about it, which I think is a further challenge we need to handle. Thank you very much.
Thank you very much, Anders. I try to think back when we really had the pandemic, and I remember that when you were criticized in the media, you often said that you took the best possible decision with regard to the best state of knowledge when the decision was made. And I really like that approach very much, and I think it is logical. But of course, it also opens up for a question in retrospect. I mean, when you are thinking back with the knowledge you have now, what do you consider to be the most problematic decision that you made? And do you even regret some of the decisions that you took on the knowledge that you have at every given time?
I think that hindsight is problematic in that way because, as I said, and I think that's not only in Sweden, I'm sure that in all countries, everybody took the best decisions they could have taken at the time being. But if you look back, I mean, there are certain things, I mean, this was a stress test for Swedish society. And I think in some ways it worked well. I think we were very happy about not closing the schools. And I think most countries would agree with us on that. But integration of certain parts of our population, that's something we should have, I think, spoken louder about in the beginning. It's a very difficult area because it's also kind of stigma, but I think we should really have spoken out about that there were certain parts of the population worse hit than others, and we really needed to help each other in reaching them. And the other areas, of course, are home for the elderly. I mean, that was a huge failure, I think. And unfortunately, a problem that we knew. I mean, there were a number of reviews of showing the problem with quality of care in these institutions, and I think we all should have helped in really early on, pointed even more closely that we are going to have a problem here, and we need to work with it from early on. Now it took too long, I think, to really be able to test and to support the staff in these places to do a good job.
Thank you. Thank you, Anders.